This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.
Hello, I'm Dr. Rob Page, and welcome to Doc Talk. Doc Talk is a podcast that is produced by the Knoxville Academy of Medicine and features its physician members giving information to patients that is helpful in terms of making their healthcare decisions. And I feel so fortunate to have with me today, and I didn't ask your name before we started, so I'm going to ask. So I have with me today
Neil Berry.
Dr. Neil Berry, who is an interventional cardiologist. And with whom do you work?
I work for Tenova Heart.
Tenova Heart. And you've been here in the area for about a year. And first and foremost, you know, we understand a lot about what radiologists do, and we understand what cardiologists do. Now, what exactly is an interventional cardiologist?
So basically, interventional cardiologist is a physician. I was trained in medicine, so I did 3 years of general internal medicine, and then I did 3 years of general cardiology training, where I learned about taking care of patients with heart disease and primarily treating them with medicines. And then I did additional training in interventional cardiology, where I learned how to treat patients with procedures using minimally invasive surgical techniques, primarily with catheter-based therapies.
So this is as opposed to, so we know about cardiothoracic surgery, which is more of the, it's a fairly invasive procedure and bypass surgery, but there's a lot of different procedures that we can do now with interventional cardiology that we don't necessarily have to do with these very invasive procedures.
Exactly. So, the heart by design is in a very difficult place to get to.
Yeah.
You have to get through the sternum, there are ribs, it's protected. So anytime you go into the heart, there needs to be a really, really good reason. So there are many times that it's appropriate to open the chest and, to directly operate on the heart, but there are other ways that we can get to the heart by going through what we call retrograde, or basically in reverse, going through the arteries and veins that lead to heart. So basically, all roads lead to Rome, so to speak.
So now when I was in training a long time ago, the only way that they could do procedures like this, when they would do angiography and it's look at the vessels of the heart and see how, if there were any blockages, was to go through the femoral vein. Nowadays, that's even less invasive than that.
Right, so we can go through the radial artery, so basically go through the wrist. We can go through the femoral artery. There are times we can go through the femoral vein and then track into the artery. There are even some centers where we can go through the carotid artery. So there's all different types of ways to get into the heart. Wow. That we've developed. And
so, and a lot of times these can be done as outpatient procedures, and not necessarily a lot with a lot of the sort of, you think about having to have a cardiac procedure done.
Right.
It can be fairly, fairly off-putting, I think, to a lot of people. But it's not so bad as it used to be.
Right. A lot of times our patients are awake, so we're able to talk to our patients, and we can gauge how their chest pain is, and so we know we're working in the right spot. So they're awake, they're talking with us, and many of them are watching the procedure on the screen, which is pretty remarkable when someone's having a heart attack.
That's incredible.
Yeah.
And so, and you certainly can gauge how a patient is doing during the entire time, gauge their pain, gauge how their heart is working, etc. So, well, we talked a little bit before we started. And one of the topics that you wanted to cover today, we understand a lot about the heart in terms of coronary artery disease. Though you wanted to talk about something about aortic stenosis.
Right.
Now, first of all, tell us exactly what is aortic stenosis.
Exactly. So a lot of times we use the term heart disease, and we don't really get into the specifics of heart disease just because it's such a big global term. But aortic stenosis is a particular type of valvular heart disease where the aortic valve, which is basically about the size of a 50-cent piece, starts to narrow, and that can happen as we age. It can happen sometimes when we're born. Some of us are born with certain diseases of the aortic valve, things like bicuspid aortic stenosis, for example. And that valve starts to narrow, so it's kind of like a little doorway. So imagine if we were trapped in a room and we couldn't get out of the door, what would happen over time? We wouldn't be too happy. And so basically, aortic stenosis is a surgical disease where we have to open that aortic valve. There's not a medication that we can give a patient to try to prevent that.
So if you had aortic stenosis, and it's interesting, you mentioned a 50-cent piece, and I think, nowadays millennials will have no clue what that is, because they're like, what's a 50-cent piece? Because they don't exist.
The size of a large lapel
That's
pin,
exactly
maybe,
That's exactly right. But then again, they don't have aortic stenosis necessarily.
That's
so
right.
I mean, it'd be something you would be thinking about more in older patients who would know what a 50-cent piece is, like people like me. So, but what sort of symptoms would a patient come up with if they had aortic stenosis? What sort of things would they notice, or what sort of things would maybe their primary care doctor notice if they had this affliction?
So one of the first symptoms is fatigue. A syncope, where patients will pass out, is another very alarming symptom that we see in the advanced stages of the disease. Chest pain, especially chest pain when they start to exert themselves, shortness of breath, and ultimately aortic stenosis can lead to heart failure. It can cause the heart to fail. And so symptoms of swelling, shortness of breath when we lay flat. It can lead to sudden death, and so when aortic stenosis starts to approach the critical phases, it's a deadly disease.
So it's something that can be managed maybe in the earlier phases if we catch it, but is potentially life-threatening. It's something that really should be pursued.
Absolutely.
So now, what sort of patients would be more at risk for developing aortic stenosis?
So certain patients, like I said, can be born with this. Right. So in bicuspid aortic stenosis, patients that have had exposure to radiation, perhaps if they've had radiation from prior cancer, malignancies. Also, as we start to age, the aortic valve starts to calcify, and as that gets more and more calcified, it starts to stenose, and so it gets smaller and smaller and smaller, and ultimately that creates a big problem for the heart and all the blood that gets to the rest of the body.
But this is not now, and traditionally in the past, and I say by the past, 20 years ago or so, this would have been something that we managed strictly surgically.
Correct. The only option at that point in time, 10, 15 years ago, was in order to open the chest and replace the aortic valve with traditional sternotomy. When I was in training and fellowship and even in residency, they started to develop a TAVR, or transcatheter aortic valve replacement, which is a procedure that I was trained in. And it was really revolutionized interventional cardiology in that we were able to basically perform an aortic valve replacement while someone's still awake.
Wow.
And
in the past, this would be something you'd have to go on like a bypass machine.
Correct.
Yeah.
We would have to stop the heart.
Yeah.
So many patients think about the trauma of opening the chest and doing a sternotomy, and that's certainly a large part of the recovery time. But on top of that, we have to stop the heart in order to operate on it. If you think about something as intricate as the aortic valve and the surgeon is operating, the heart really needs to be stopped for that. And many patients have a hard time coming off the heart-lung machine or the bypass pump if the heart has been arrested for a period of time.
And are there certain age groups that would be, we think about sort of the limitations that are involved with surgery, about having patients who are in, not necessarily excellent health, but at least healthy enough to survive the surgery. Is this the same situation for interventional cardiology, or for doing things with your type procedure?
That's an excellent question. So that's been aggressively studied. So initially, this modality was really only done in what we call prohibitive surgical risk patients. Mm-hmm. So patients that would not survive a surgery, and surgery was out of the question. So those patients were studied. And we found they did much better than medical therapy, which there really is no medical therapy. But we found in initial trials that these patients lived longer and had improved quality of life. Then we started doing this in what we'll call high-risk surgical patients. Then we did it in moderate-risk surgical patients. And then when I was in fellowship, we actually did patients that were called low-risk. So patients like someone in their 60s or 50s that would have the option of surgery or with a TAVR or transcatheter modalities, and we found that those patients did just as good, if not slightly better, in the minimally invasive arm.
So strictly for the procedure, what exactly would this entail for a patient? If they knew that they were going to have, they'd been examined by a cardiologist, they had the imaging studies done, they knew this is what they had. What typically would a hotel? We
don't usually do this in the hotel.
I was going to say, I was talking about a Freudian slip.
Right.
I was going to say, what typically would the hospital stay entail? When would a patient be admitted? How long would they generally stay? And what would they expect in terms of follow-up care, activity, things like that?
That's an excellent question. The first part about what you mentioned is there's a lot that goes into the procedure. So they've had imaging ahead of time, and we really approach this as a team approach. That's probably one of the biggest advantages that patients go through TAVR is that they're evaluated by a comprehensive team. Not only myself as an interventional cardiologist, but non-invasive cardiologists have seen them, a surgeon has seen them, and we discuss their care together, and we reach that as a team. That's something that we've learned from our oncology colleagues, where we have radiation oncologists and surgeons and medical oncologists all discuss together. So two heads are better than one. And so as a team, we've looked at several scans and heart catheterizations, et cetera. So we've planned the procedure so we know exactly what's going to happen, what we're going to do, what type of valve we're going to put in. But to answer your question in terms of the hospitalization, the patient comes into our hybrid cardiac catheterization lab. They're given sedation by a nurse anesthetist, and then we put in a temporary pacemaker. That the role for that is to speed the heart up so that we can drop the blood pressure so the valve stays in stable position. We deploy the valve. It's a similar valve to the surgical valve. There are two different types. There's one that is self-expanding, and then there's one that's balloon expanding. And the engineers have figured out how to mount a surgical valve onto this catheter that goes across. Once that's
amazing stuff.
Once that's deployed, once that valve is deployed, that takes just a few seconds, and as long as everything looks good with the echocardiogram, we basically remove all of that equipment, and we sew up our little incision that's about the size of the tip of my index finger, and then the patient goes to the recovery area, and we monitor them overnight. And then they usually go home the next day.
Wow.
We see them again in 30 days to make sure their valve has been stable and that they're doing well, and then we see them again in a year follow-up.
Now, typically in terms of a surgical procedure, I know that there are several options that you can go in and you can try to separate the valves in some situations, or actually do an entire valve replacement.
Correct.
And that would entail taking the valve out and then putting in a new valve?
Right, and so it depends on the valve we're talking about. You know, if we're talking about purely the aortic valve, typically that's dealt with in terms of a replacement. Sometimes we can repair the valve, and that's what surgeons do.
Right.
But in this case, we basically put this device in where the old valve was and basically displace all of that as it's deployed.
So is there a part of it where you actually are taking out the prior valve?
No, not in TAVR or minimally invasive surgery.
Now, so how does that work in terms of, I'm interested about, to think about, because you have a valve that's sitting there already.
Right.
And then you put another valve where it was.
Right.
Does it just push the valve out of the way?
Correct.
Or? Oh.
It pushes the native leaflets out of the way. And that actually is one of the advantages of the procedure, because that prior leaflet, that calcium that's there, it's what anchors the valve so it stays in place. So that's one of the things that's
just amazing stuff. A lot of this is, this is learning for me too, because, hopefully it's, knock on wood, not anything I would have to learn about for, for me particularly, but given my field of medicine, it's not something we ever get exposed to. And just the, the advances and the technology and the simplicity, a lot of these things, with a lot of these things. I realize technically it's not simplistic, but just how how you're able to do these procedures in just fairly with a fairly limited patient without having to have a lot of things done before surgery or after surgery or long hospital stays. It just blows the mind. So.
And in the past, we might not consider doing a lot of workup for a 95-year-old patient,
right.
Because they might not tolerate the surgical therapy. But in this case, it makes a difference because it can really change their quality of life and their longevity.
And this is something that as you get older and older and older is more likely to occur.
Correct.
So I mean, it's even if you're in relatively good health, say when you're 80,
correct.
By the time you're in your 90s, it may be something that's just developed, over that period of time.
Correct.
So, well, that's absolutely amazing. So, give us some information if I'm a patient and I hold this diagnosis, or if I'd like to get worked up, additional cardiology workup for any sort of symptoms that I'm having. How would I get in touch with you?
So you'll talk to your regular doctor about that, and then they can send you to
so it's generally done as a referral?
Typically, yeah, it's as a referral. And so, again, my office, I have a practice at Tenova, Turkey Creek, or formerly known as East Tennessee Heart Consultants. So I work with
And y'all have a website where, as a
do.
patient, I can get additional information about this?
You can get that on our website.
So do we have a web address? Because if you do, I'm going to put it at the bottom of the screen later. Yeah. So in Magic, if you don't know it off the top of your head, that's that's cool. So we'll just have it at the bottom of the screen.
Right.
We'll have that sitting there for the
Correct.
patients to take a look at. And your office is located?
I have an office at Turkey Creek Medical Center over on Parkside Drive.
So right over there by all the shops and stuff.
Exactly.
In
you go to Walmart and get your
in the newer hospital over there. And we'll also have a phone number if they want to contact your office and get in touch with you.
Sure.
So we'll put that at the bottom of the screen too.
Perfect.
So. Well, that's amazing stuff, and I'm always, to me, it's a learning exercise too, to get a chance to hear about all the amazing developments that are occurring in medicine, and just how procedures that used to be so incredibly invasive, and used to require a significant amount of recovery time, are not so much. Patients can actually go and have the procedure done, and I would presume, be able to go back to work, or sort of a normal work schedule not too long after that, or at least normal physical schedule, or.
Correct. That's probably the biggest motivation that I had to learn that procedure, and one of the reasons I've researched it, and why I love doing it, is because patients really come from a point where they're many times miserable. They're very short of breath. They have lots of chest discomfort. Some of them can be actively dying with this disease. And in a matter of minutes, once the valve is fixed, their gradients and velocities basically disappear. And so at that point, they're able to get a breath. They're able to walk. They're able to do a lot of the things that they have been wanting to do for years, but just weren't able to. And so that's what really makes it all worth it.
Very satisfying for you, and very satisfying for the patient as well.
Exactly.
And it's just anyway, I just always constantly find these things amazing. So, well, thank you so much for joining me here today with Doc Talk and giving us information about aortic stenosis. And with that brings this episode to a close. Thank you for joining us here at Doc Talk. Doc Talk is a podcast that is produced by the Knoxville Academy of Medicine and features its physician members giving information to patients that's helpful in terms of making their healthcare decisions. I'm Dr. Rob Page, and thank you so much for joining us.
This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.